So this is the overview. I'm going to just go through the biology of the Department of Health NHS ABN response, specific questions that have been arisen. I'll go through a few case studies, the issue around service redesign. I'll go through undefined risks and then science communication. So actually this article that came out in last week's Economist is a really good scientific article in the sense it was well written in lay language. As you know, corona refers to the shape of the virus in 2D. Actually, when you look at the virus in 3D, it looks more like one of those naval World War II submerged bombs. And basically refers to the shape with the spike protein sticking out of the membrane. It's actually a very simple single-stranded RNA positive strand. In other words, an RNA gets transcribed and releases its protein. We know a lot about coronaviruses. They've been around for a long time, and they infect not only humans, but a multitude of organs. And it was felt that this particular coronavirus got to us via animals because of the close proximity between humans and animals in the Chinese markets. Unfortunately, the Chinese like eating exotic wild animals for food. And the current theory is it comes from a pangolin, as Jeremy Clarkson, he likes to refer to as a walking artichoke. There is a well-defined biology around this. So as you can see, the spike protein binds to the ACE2 receptor, a attention converting enzyme. And that may be one of the reasons why people with hypertension are particularly susceptible to the severe forms of this infection, because they may have upregulation of the ACE2 receptors. And then there's a cleavage protein, TMRS2, on the enzyme, which basically cleaves the coat protein, allowing the envelope protein to translocate into the cell, then releases this RNA. We get viral protein replication, and there's a replicated enzyme that's clearly a drug target. I think what's quite interesting is that a large number of existing antivirals may work against the replicase activity of this virus. And some of these antivirals are already in phase 2 trials in China and elsewhere to test whether or not they can work against COVID-19. The one that really impressed me is chloroquine. You've probably seen in South Korea, the mortality from COVID-19 is down at about 0.2%, and they've been routinely using chloroquine in their cases that have been admitted to hospital. And, either chloroquine's working or something else is doing it. So, if I had severe COVID-19, I'm almost certain I'd want chloroquine. But the good news is, though, there's existing antivirals that may work against the virus. There are a large number of trials happening, and there's screening studies being funded by NIH in the United States and the Bill Gates Foundation to do rapid screening. So we may get drugs into trials and into clinic very quickly with this virus, which is a remarkable story. The reason why we got a pandemic, so if you're interested in epidemiology, one of the main reasons this virus is ideally suited for a pandemic. And actually, the World Bank had put the risks of a pandemic from a SARS-like virus at over 5%, close to 6% when it was doing its actuarial analysis. So the World Bank had a 1 in 20 risk of a SARS pandemic occurring. And despite that, governments didn't get prepared. The reason why it's caused a pandemic, because of the long asymptomatic period. It may be up to 14 days, but most people think it's probably up to about 5 days before you start shedding the virus, before you become symptomatic. There is clearly a group of people that are asymptomatic shedders. We don't know what the proportion is, and so as soon as we've got a serological assay, we'll be able to detect that. The R0, which is the number of people an infected person infects, is about 3. Which is important because that's one of the reasons why this virus has been spreading exponentially. The original estimates were down at 2.3, but the latest estimates are putting this R0 between 3 and 4. There's also been a group of people called super spreaders. These are people who infect more than the average of 3. And why people are super spreaders is unknown, maybe because they shed more virus. The big worry, though, with MS patients is do immunosuppressed patients. Patients on immunosuppressive DMTs have a larger viral shedding load, and that will only be established once we actually get people with MS infected and they are studied. Super spreading may be due to amount of virus shed at the time or the duration of shedding. And so people that are super spreaders may actually shed the virus much longer. Please note that although we think the virus is expressed via secretions from the nose and upper respiratory tract, people with about 3 to 4% of people present with diarrhea, and it's spread in the feces as well. So spreading of this virus is not only upper respiratory tract secretions, but can occur elsewhere. I think what drove this pandemic so quickly was excessive national and international travel, particularly around the Chinese New Year, and also the fact that air travel is now ubiquitous. The other factor is obviously COVID-19 is a new human pathogen, and there's no herd immunity. So this is another reason why it's spreading like wildfire, because if there at least some background immunity, it would have slowed down the spread. Just to show you that the Chinese New Year last year, where this we think has been the main reason for this spread, was the largest migration of humans ever recorded. So 400 people traveled on Chinese New Year. And that traveling was not only within China, it was international. As you know, Chinese people all over the world, and a lot of them go home to spend New Year with their families. So we think the Chinese New Year was the real driver of the pandemic. This is just an image I pulled off the web just to show you how interconnected the world is. And so you can imagine if you've got an asymptomatic period of a week, say, and this is how people are traveling between Asia and the rest of the world, it's not surprising this virus has gone global and become a pandemic. I would refer you to the Johns Hopkins website, which gives you an up-to-date number of cases affected across the world. This is from yesterday afternoon, and as you can see, we're very close to 200,000 cases worldwide, and you can see Great Britain is close to the top there, almost 2,000 cases, and what you've got to realize that we're in the exponential increase. So by today, I wouldn't be surprised if there are 4,000 cases reported from the UK. The danger, though, is the UK is stopping testing in the community, so the actual number will be much, much higher than what's officially reported via this website. Just to show you the cases, as you can see, China has flattened its peak, and it's now only reporting very small number of cases on a daily basis. But other countries are increasing exponentially. I put up this figure from the editorial that came out last week in the Lancet from Italy, just showing you that Italy was in the exponential rise, number of infected patients actually going up very closely modeled according to the simulated rise. So they are, of the 9th of March, 8th of March last week, we're still in the exponential increase. Obviously, when you put in draconian measures that they've done as they shut down Italy, this will take about 7 to 10 days to see the flattening off this exponential rise. That's one of the things, because people have been, who have been infected are still going to get symptoms in the next week to 10 days. You're not going to see a shutdown like we're having across Europe having an effect on these curves for about 10 to 14 days. We're predicting that what's happened in China will happen in Italy, and it will flatten off. I think the scary thing is the graph on the lower right, just showing you the number of ITU beds that are going to be required, and that is quite scary. Italy's going to run out of, well, they have already in some regions run out of intensive care beds and have had to triage patients for ventilation, and that's the worrying thing about the NHS, and that's why it's so critical to for us to try and adopt and respect and implement the government's policy of social distancing and social isolation to try and prevent the spread or flatten the peak of the curve, so we can actually manage all patients who need intensive care with intensive care beds. I'm not going to go through it, but the clinical characteristics of this virus are like other coronaviruses, very non-specific, flu-like infection, upper respiratory tract symptoms with the temperature, and the first 1,000 cases, 1,000 plus cases were reported in New England Journal of Medicine 2 weeks ago, and I'd urge you to read the article. What is interesting, though, is the severe infection that hits the lung happens as a delayed response. It doesn't occur in the first week. It normally occurs in the second week. And we think it's nothing to do with the virus. We think it's due to an immune response to the virus, and it presents with an adult respiratory distress syndrome. And the current thinking is that it's actually an immune response to the virus. And paradoxically, we think immune suppressive therapies or using immune type suppressive therapies may dampen down this ARDS. This is why a large number of immunosuppressive therapies, including anti-IL-6, are now being tested in the adult respiratory distress phase of this disease to try and improve outcomes. I think the word out there is that steroids don't make a difference. Steroids may make it worse. And there has been some reports from France saying that using anti-inflammatory medication, non-steroidal anti-inflammatories for the flu-like symptoms, actually can make this disease worse. So the French are recommending that nobody should be using non-steroidal anti-inflammatories to treat the flu-like symptoms. If you are going to use an antipyretic, you should be recommending paracetamol. Now, that hasn't been confirmed. The NHS hasn't put out a statement based on that. I sit on this immunosuppressive committee for the NHS, and we're reluctant to replicate the French advice until we have more confidence in that observation. But it is an anecdotal observation that people taking non-steroidal anti-inflammatories to treat the flu-like symptoms are much more likely to get severe respiratory complications as a result of coronavirus. And I think it's out there on the web. Most patients are asking questions in social media around non-steroidal anti-inflammatory usage. This is the clinical characteristics, nothing special. I just want to point out that in the Chinese series, 4% of patients presented with diarrhea. Nothing special here at all. So this is very non-specific. So, there are other circulating viruses out there. So I assume if you're going to get any other rhinovirus or even an influenza type infection, it's going to be assumed to be COVID-19 until proved otherwise. And I think that's something we need to keep in mind, that there's going to be a large number of false positives based on symptomatic reporting. But we have to clamp down on these just in case, because community-based testing has been suspended by the NHS. The main risk factor for severe infection and mortality happens to be age. And if you look at that figure there from the first 150 cases, it's quite worrying that the age, probably from about the age of 40, 45, the mortality increases. So age is by far the most dominant risk factor. Sex is also a risk factor. All the deaths, 80% of the deaths in Italy have been males. And the important comorbidities are hypertension, diabetes, smoking, and severe asthma. I put question mark on immunosuppression because that's out there as a risk factor. But based on the Italian experience, chemotherapy patients on immunosuppressors don't appear to be doing any worse anecdotally than people that are not immunosuppressed. So I'm not sure about immunosuppression, but I think we need to apply basic principles that if you are immunocompromised or immunosuppressed, you're much more likely to have severe viral infection at the moment. That's the advice we're giving our patients. Okay, so just to say to you that there have been some guidelines put out. So the Italians broke first, and they put out their guidelines, and the ABN came second. Essentially, they're in line with each other. And there's just been an update today from the ABN saying that NHS England are going to allow us to use natalizumab more freely in terms of its actual European Medicine Agency label. So you don't only have to have rapidly evolving severe, we are also going to be able to use it in patients with highly active disease, simply because we think that natalizumab is a safer option than some of the other immunosuppressive therapies. Essentially, they've actually classified, the ABN's classified disease-modifying therapies into green or red, okay or not okay. Anti-CD20 ocrelizumab is in pink there simply because if you are really stuck with somebody with highly active disease, it's probably the safest of those red ones to use, simply because it's a pure B-cell depleter and has a minor impact on T-cell function, which is meant to be the antiviral component of our adaptive immune response. So obviously the platform therapies, interferon GA, teriflunomide, dimethyl fumarate are safe. They tend not to be immunosuppressive. I'd be a little bit more careful about dimethyl fumarate I think this line refers to patients that do not have a lymphopenia. So if you are on dimethyl fumarate and you've got a significant lymphopenia, I think you have to treat that particular group of patients, which were probably small, as being a higher risk. Natalizumab has been given a green light. I still have quite concerns about that, because we know from the natalizumab phase 3 program there was a higher risk of upper respiratory tract infections, and it does block trafficking of lymphocytes into mucosal surfaces like the gut. So it may actually create a niche for viral replication. So I wouldn't be surprised if natalizumab results in super spreaders. And it also blocks trafficking of lymphocytes into the central nervous system. And there is emerging data that coronaviruses and COVID-19 are neurotropic. So you don't really want to get a CNS infection with COVID-19 and be on natalizumab. So I think we just need to watch this space. Obviously, as patients get infected with the virus on natalizumab, we'll know how safe it is. The no-nos are cladribine, alemtuzumab, and HSCT. So the guidelines have recommended suspending dosing. I personally think it needs to be a little bit more grey than that, and I'll show you a case study later on where I think it needs to be a little bit more grey than that. But as these are immune depleters, you don't want to leave your patients immunodepleted and acquiring COVID-19, because they are obviously going to need their CD4 and CD8 cells in particular to fight off the infection. Anyway, I would urge you to download the latest version. It's on the ABN website and read it. I think it's kind of a framework for advising patients and for making decisions about disease-modifying therapies. Another thing that came out which threw us is the guidance about social distancing that the Public Health England put out 2 days ago. And they were advising those at an increased risk of severe illness from coronavirus to be particularly stringent in following social distancing measures. And on that list is multiple sclerosis. I personally think that MS is on this list, as you can see on this list, MS is really referring to people that are on immunosuppressive therapies, I suspect, and maybe more, those patients with a more advanced disease that have recurrent respiratory tract infections or at risk of aspiration pneumonia. My personal opinion is somebody with MS is young, with no disability, who is fully functional, who's not on immunosuppressive therapy, shouldn't be at any higher risk of getting COVID-19 infection than somebody in the general population. So I think this advice is unfortunate because it's generated an enormous number of questions from our patients, and it probably should have been more nuanced, and we should have had an asterisk there explaining what we meant about the subgroup of people with MS that are at increased risk of severe infections. So questions. I think, as you know, we're in the era of the expert patients, so there's no way we've got ignorant patients out there. They are extremely anxious, scouring the internet, on social media groups, be it Facebook or whatever, and they're coming up with management options on their own. So I think we have to, as a community, engage proactively with the COVID-19 pandemic and give out evidence-based advice if we can, or we have to have some kind of opinion based on scientific principles to advise them on what to do. And we have to buy into the flattening of the curve. If we are going to want to avoid what's happened in Italy, where 65-plus-year-olds have been denied ventilators, we are going to have to personally not spread the virus or encourage family members and general community as healthcare professionals to socially distance, socially isolate if there's a query of being infected, and to try and flatten this curve as much as possible. I don't know if you watched the Channel 4 BBC News last night. This is the most critical factor. And our chief Patrick Vallance, the chief scientific advisor for the government, was saying reducing the death rate, mortality rate. Ideally, what he would consider a success is bringing it down from the hundreds of thousands to the tens of thousands. So he would consider a successful flattening of the curve campaign, limiting the numbers of people dying from this infection to tens of thousands, rather than hundreds of thousands. And I think that needs to be imprinted on the minds of ourselves, our colleagues, and the general population, is that this is about saving people's lives. So this is kind of what the people have been asking. Does MS increase my chance of getting COVID-19 infection? I don't think yes, personally. To get COVID-19 infection, you need to be exposed to the virus. So if you prevent yourself getting exposed to the virus, you're not going to get the virus. So hygiene, I suspect if you're more disabled and you can't practice hygiene, then you may increase your chances. There is this issue that there is asymptomatic shedders, and so I assume that if you're on an immunosuppressive therapy, you may be more likely to become symptomatic. So in that situation, converting asymptomatic to symptomatic infection, you may be more likely to get COVID-19 disease. And similarly, you may also get more severe disease because of that. But the corollary of that is, I've already mentioned to you, the secondary complications that are responsible for severe disease are immune mediated. So there is this hypothesis going around that by dampening down the immune system with immunosuppressive therapies, you may prevent severe disease. And in fact, the Chinese are doing a trial of fingolimod in severe COVID virus infection to see if they can dampen down severe disease. So I think we need to watch this space. I don't think we should assume that because you're on a moderate immunosuppressive therapy that you're more at risk of getting severe disease. You may be, but we can't answer that question. And I'll come back to this in the end of the day. We are doing a national study to try and address this question with the MS register. Does COVID-19 cause MS relapses? I have no idea. I assume COVID-19 is an infection. We know infections can trigger relapses, but that's in the pre-DMT era. On DMTs, it's probably less likely. I assume because you get a temperature, you can get pseudo-relapses from temperature-related conduction block. That would be a generic advice. I don't think people should self-isolate unless they're severely immunocompromised, say post-HSCT, alemtuzumab, or cladribine. The rest of the population should probably just socially distance initially, and only if they have symptoms socially isolate. People shouldn't stop their DMT. That's the advice you should give. They should discuss it with the team. I think we should interrupt dosing for those immune depleters, or at least offer interruption. And a decision will need to be made how long this pandemic lasts, when to reinitiate dosing. The point about stopping dosing doesn't overcome or address the question of when to recommence dosing and what happens if we can't recommence dosing. So we may start having to, this guidance is going to change with time. Can you recommend a good source of information? Yes, there are plenty of sources. I would stick to the MS Trust, MS Society. MS Society one is pretty good. The patients have been complaining on our blog that it's not specific enough to their specific questions. I'll come to that. Should I avoid attending my hospital appointments? Yes. So our mandate from our center has been to try and transfer everybody onto telephone or telemedicine follow-ups. The only ones that are going to be coming are those for infusions and for pharmacovigilance. I think we can do everything else via telemedicine. The exception being blood and urine monitoring. We are not vigilance monitoring. We think that's really important, particularly post-alemtuzumab. We have to just take precautions in terms of them with personal hygiene, but we need to do the monitoring still. Are there any people with MS who've had COVID-19 infection? Yes. They haven't been reported in official journals, but you follow on Twitter, a large number of neurologists who use Twitter are now reporting cases in Italy, mainly in Italy, of people on disease-modifying treatments. There have been 2 with ocrelizumab, 1 cladribine, 1 alemtuzumab, 1 natalizumab, reported in small tweets. And the good news is they all seem to be doing well, but what's social media as a reporting platform for this information? What is a safe lymphocyte count? This is going to depend on person report, on your own experience. My personal opinion, it's always been anything above 800. That's a general advice. It probably doesn't refer to people on S1P modulators like fingolimod. There, the 200 will cut off according to the European Medicine Agency is a safe count. Some people have been saying 1,000. Some people say 500. I've always used 800 per cubic millimeter, and that's based on my experience with azathioprine and other immunosuppressive therapies. Yes, I've just done significant lymphopenia on DMF. I've always had significant lymphopenia on DMF has been 800. As soon as our patients drop below 800, we check. If they're still below 800, we stop. The problem about long-term persistent lymphopenia on DMF, it takes a long time to recover. So the stopping the DMT is when somebody, so this question about should somebody stop their DMT when they get COVID-19 infection or symptomatic infection. The problem is, as I said to you, these people are going to be stuck at home, asked to self-isolate, and we have no idea if they've got COVID-19 or not. So I think this advice really refers to people with severe infections requiring healthcare interventions or admission to hospital with confirmed COVID-19 infection. I think we must say to people that have got mild infection, that are managing themselves at home, don't stop, see what happens over the next few days, and only if they need to be admitted to hospital with severe respiratory symptoms should we stop the therapy. Otherwise, we're going to be stopping the treatment and creating problems for ourselves, even with common upper respiratory tract infections that may nothing to do with COVID-19. Hi Gavin, who the first 5 days, yes. So my advice about cladribine is somebody's had the first cycle of the first course, we should complete the course. The reason I say for that is that we've got data that one course is effective, and that's based on the Australian data from the initial formulation. They're going to be lymphopenic anyway, and then putting them onto another DMT will interact with that lymphopenia. So my personal opinion would be to complete the course and just make them extra vigilant about infections. I must point out that the level of immunosuppression post-cladribine is very mild. Most people only drop their lymphocyte counts by about 40 to 50%, and their CD4s and CD8s remain above normal. And in the trial and in the extension trial, we never saw any signal with severe viral infection. So I actually think it's been a mistake by the ABN and the Italians to classify cladribine in the same ballpark as alemtuzumab and HSCT. So it's a relative immunosuppression. I mean, cladribine is a much bigger, better B-cell depleter. It's almost like a small molecule anti-CD20, and we haven't seen a severe viral infection. So I don't think people with cladribine will have issues dealing with viral infections. So I think this is a soft call. Anyway, people on DMF who've got a lymphopenia, there's a question there, patients on DMF who are persistently lymphopenic and have elected to continue on treatment and accept PMRS, what would you advise? My personal opinion there would be to advise them stopping their drug. In this situation, it's very difficult to start them on anything else. You may want to put them on an interferon or glutaric acetate. Interferon would make more sense simply because it's antiviral and there's a theoretical advantage to antiviral. Teriflunomide, yes. One of the contraindications to teriflunomide is you would like them to have their lymphocyte counts back to normal. Another option is to put them on natalizumab if we can. There has been a request put in by the ABN to lessen the dosing criteria for natalizumab, but Malcolm Quayle and NHS England would only go as far as allowing us to use it under the European Medicine Agency label, which means you have to have a highly active or rapidly evolving severe. So a patient who's stable on DMF with a low lymphocyte count with no relapse is unlikely to be eligible by the Blue Tech system for natalizumab. Should the patients on a DMT be offered test if they have symptoms? No, I don't think so. I mean, there are hundreds of thousands of MS patients with tens of thousands on DMTs. The NHS can't cope with diagnosing people with severe infection, and I just don't think we should overload the system. Based on the scientific principles, people with MS are likely to have, the majority will have mild self-limiting infections. They should be managed at home. And once the serology comes available, we can test them to see if they did have that infection. So my advice would be same to a normal person: stay at home, bat through it. You should make a recovery without any medical intervention. And if they are going to use over-the-counter antipyretics, tell them to use paracetamol, not a non-steroidal. Would I advise patients on fingolimod to self-isolate? No. My personal opinion is they should just follow the current advice in terms of social distancing. The problem with self-isolation is the risk won't disappear. So we anticipate that this epidemic is going to last 3-4 months. So to self-isolate for 3 or 4 months is almost impossible to implement. And this epidemic may last 6, 9, 12, or 18 months. So I think we need to be a little bit sensible about this. People have to continue their lives, and self-isolation will only really work for a few weeks. It won't work for months or years. So I would say no, but you must make sure that those patients are educated about personal hygiene and social distancing. Can patients have the first half or first cycle of ocrelizumab, wait for the second half until the... No, my personal opinion is ocrelizumab is exactly the same as with cladribine. If they've had the first half of the first dose, they should complete it. And my personal opinion is it's different to the ABN, and I'll tell you why. I actually think the risk of severe COVID virus infection of ocrelizumab is low because the T cells are left intact. We did not see a severe viral infection signal in the trials. Um, Almost all the severe infections were bacterial, urinary tract infections, bacterial pneumonias, and cellulitis. So I think people on ocrelizumab deal with viral infections reasonably well. The thing about ocrelizumab is in the rheumatoid studies, when there was short dosing intervals, only given for 6 months, people had a high risk of getting neutralizing antibodies. And I think we need to, so the problem is if you just give one 300 milligram dose, or even one 600 milligram dose, those people are much more likely to come out of that with NABs. About 20%, 1 in 5 will get NABs, which means they won't respond or they'll get infusion reactions next time you use it. So I'm actually saying to my patients that I personally think their risk of infection and severe infection is no different to the rest of the population. If it is increased, it's increased by a small amount. And if they don't finish 3 or 4 doses of ocrelizumab, they are going to put themselves at risk of neutralizing anti-ocrelizumab antibodies. And that's kind of driven by RA data. So my advice differs slightly to the ABN and then Italian neurologists in regard to that. But even saying that, there are some patients who don't want to take the risk, and we've put patients of mine and we've had to interrupt dosing. So there's this is opinion. There's a little bit of data to support the opinion, but at the end of the day, I think it's up to the patient to decide on what to do. So what would you, by definition, the patient have a low white count or below 3.8, what would be concerned? So if you go to the hematologists and the immunologists about neutrophil counts, to be honest with you, a large number of people walk around with neutrophil counts of between 500 and 1.5. They have congenital neutropenia and they don't have any increased risk of infections. So the immunologists and hematologists only start getting worried when the counts drop below 500. This is neutrophils, and below 200. So the risk of neutropenic sepsis only really emerges below 200. But I mean, to be honest with you, most of our patients don't have a problem with neutrophils. Even our alemtuzumab patients, neutrophil counts are back within a day. And the worry with the worry is HSCT, so I do think we should suspend HSCT if possible until after the peak at least subsides. The risk with alemtuzumab is the monocytopenia. The monocytes stay down for a few weeks, which is probably driving the listeria risk, not a neutropenia, but a monocytopenia. So what would your definition of immunocompromise be in terms of white cell count? Yes, so white cell count is difficult. So for neutropenic sepsis, less than 500 for neutrophil count. For lymphocyte counts, less than 800 would be my cutoff, except if you're on a S1P modulator, less than 200 based on European Medicine Agency guidelines. The reason why I say we have to use 200 for S1P modulators is because in the fingolimod phase 3 development program, there was no correlation between infections, severe infections, and serious infections requiring hospital admission and the lymphocyte count. So people were as likely to get a severe infection if they had a lymphocyte count of 5 or 600 as if they had a lymphocyte count of 250 or 300. So the peripheral lymphocyte count on S1P modulators is a very poor guide to the level of immunosuppression they have. And simply because the lymphocytes are trapped in secondary lymphoid organs, they're still functional and they can deal with infections. Okay, I'm going to move on to the next slides, if I don't mind. Keep asking questions. This is great. So just to say to you, since yesterday, preparing for this, I've actually created a website. I've got a website that's under development called MS Selfie, but I've created a COVID-19 section where I'm actually going to be answering or taking information off our blog where I've answered questions and putting it into a curated site. And I may want to ask people out there who want to help me answer these questions so we can keep it up to date. And I'm going to actually answer the questions in categories just to help us. So you may want to use this as a reference source. I think Sarah will put the link on the MS Academy website. I'm also going to be putting up case studies. I've been answering enormous numbers of email queries from patients. I'm getting permission from them to anonymize their case histories and deal with this question. And I've already put up 6 in the early hours of this morning of questions that I have been asked. And these have been all two of them. I'm going to just talk through now. So this is a patient, not mine. She emailed me. She's from up in the Midlands. So she's a 51-year-old lady with active relapsing disease. She was due for ocrelizumab infusion in 2 weeks' time. She has active MS. She had a relapse in new lesions on MRI scan, and EDSS has progressed from 2.5 to 3. So she has got, and this all happened on GA, conjectural mass state. So she has got highly active disease with clinical MRI and disease progression. And so she was actually contacted by her team to delay ocrelizumab treatment indefinitely and was recommended to start dimethyl fumarate in the next week. Her job also involves dealing with members of the public, and she works in a busy retail environment. So this is actually a tricky question. So the question is, could you advise me if it's okay to start ocrelizumab? My MS team are willing to provide or whether I should self-isolate after treatment because of the amount of contact I have with the public. Does anybody want to give this a go?
We have I'm Dr. Tanveer from Preston. Can you hear me?
Yes, very well.
Yes, thank you very much for organizing this. This is very helpful. We have quite a few nurses and trainees here with us. We have a similar case, and I had a long discussion with the patient. And in this scenario, I think, the science is there to suggest that maybe we should give these patients Ocrevus, but they should self-isolate at home. And in fact, for the next few months, they should, until the whole pandemic is over, they kind of exercise more caution. But this is something, I'll have a chat with the patient again. And I had similar thoughts whether I should de-escalate her to something else, but she is so aggressive. And she's not a candidate for Tysabri either, because the very high JCV titer already she has. She's a treatment naive patient, but her JCV index is already 3.54. I know we have time, but she's really worried and she does not want to proceed with other options. So yes, for this patient, I will have a frank discussion with the patient and see what she wants. And definitely, at least the science is there that it shouldn't be any worse. So
yeah, so I would actually think that's a reasonable approach. Obviously, this lady's MS is failing platform therapies. We would like to escalate her. The current guidelines would suggest natalizumab. So this lady could actually now, under today's guidelines from the ABN, and because NHS England have now allowing us to use it in highly active, not only, so she would actually probably be suitable now for natalizumab under today's guideline. So this particular lady, I think if you wanted to give her a high efficacy drug, would be natalizumab, or ocrelizumab would be appropriate as well. I don't know about this patient's JC virus index, but even if she was JC virus positive, you could probably still start on natalizumab, give her monthly for 6 months, then maybe extend it after that to 6 weekly, and then make a decision about de-risking her or continue on it depending on her risk aversion later on. Of the green lighted therapies, I don't personally think I would like dimethyl fumarate here because I have no idea if she's going to be one of these 15% of patients that's going to develop a lymphopenia. I would probably, if we were going to go for a mid-tier drug, would go for teriflunomide, simply because teriflunomide is not immunosuppressive, and it also has broad spectrum antiviral activity. So, and so this particular patient, if she really wants a high efficacy drugs, natalizumab or ocrelizumab, based on the guidelines, natalizumab would be safer than ocrelizumab, or go for teriflunomide. Okay, the next patient is, I've already addressed it. This is a lady who failed DMF, had a brainstem relapse with new lesions on an MRI scan. She's had her first course of first cycle of oral cladribine, and she's due for a second cycle. The guidelines have come out saying stop cladribine dosing, and my personal opinion is to finish it. She's really committed herself. She's got lymphopenia. She's going to get a little bit more lymphopenia after the second cycle. We know that once you've had one course, you're more likely to respond to the drug. There's good data. I think de-risking on to another DMT when she's already had cladribine is an unknown territory. And so I would just say, let's finish first cycle, make sure she's well educated around social isolation. Okay, what I want to say to you is, because we've got this mandate from the NHS not to see patients, I think this is an opportunity to rethink the design of how you deliver your services, because we're going to have to be creative. And we now are having to convert all our clinics, including new patients, to telephone consultations. And I've always said to you, you know, that this is just our number of patients from DMTs. We're just not coping, you know, with the current model. And the current model really is to try and shift things onto the patients. You know, can we do things differently during the COVID-19 pandemic? And can we take that practice change into our future MS services? And so clearly the NHS hasn't changed. This is a picture of the Manchester Royal Infirmary from 1952, just after NHS started. Doesn't look any different in my hospital now, except that benches are slightly more modern, but we still bring patients to our hospitals, make them wait for an appointment where they're going to get exposed to infections, when we can do things differently. And I've got this little figure you may be seeing. There are different models, and we're going to have to adopt, get away from the synchronous and this bottom left-hand corner where people are going to be seen at the same time at the same place, and move to asynchronous consultations or using telemedicine with different geographies, and maybe even setting up group clinics. And I don't know if I'll go through this, but there's a large literature on things we can do. We in our centre are going to be using telephone and WhatsApp. Some centres I know have got Skype, and some have got dedicated NHS-approved platforms. Just to say to you, the NHS has approved WhatsApp as a platform because it's encrypted to communicate with patients. So a lot of our FaceTime consultations will be done through WhatsApp. So these are some of the service changes. I think you can use the telephone, say Skype consultation, to triage new referrals. Clearly, you'll be able to determine from speaking to them on the phone if they have to have a face-to-face appointment. It's quite interesting, but there have been some people who've done some work. Is what can you do via a FaceTime or a WhatsApp consultation in terms of the neurological examination? So you can get people to walk, heel, toe, hop on either leg, squat. You can do eye movements. You can do upper limb coordination. So there's quite a lot you can do on the neurological examination using some of these telemedicine portals. And sometimes that may be sufficient to get a rough idea from a neurological perspective what's going on in the patient. The question you need to ask yourself is, can you delay any investigations? You know, does this patient need to be investigated urgently, semi-urgently, or can they be delayed to prevent them having to travel and getting exposed to the virus? And I think that's going to have to be the strategy you take, is when you do face-to-face telemedicine referrals, is deciding who needs to come up for a face-to-face and who can have delayed investigations. I also think that it's very difficult to do telemedicine consultations with somebody via an interpreter. So that may be one of the reasons why you need to bring up patients who speak a foreign language. It's not easy to do telephone consultations via an interpreter without having to see the body language. The question I'm going to say to you, is it feasible to do a relapse assessment online? I think yes. Our nurses have been doing relapse assessments by telephone for decades. And my personal opinion is, while we're having this COVID-19 pandemic, is to try and avoid use of steroids for treating relapses. To be honest with you, the impact steroids have on relapse recovery is minimal. You know, people will get to the same level of recovery with or without steroids. All the steroids does is speed up the recovery. And based on the fact that steroids may worsen, may make you more susceptible to having symptomatic infection, and may worsen the disease, I think we should put a mandate out there. We're trying to avoid use of corticosteroids during the pandemic. I think we can do verbal consent for email contact, so that's kind of a useful way. And I think when we are speaking to patients, we should mention to them that we are going to have this MS register study to see how COVID-19 impacts on MS and how MS impacts on the viral infection. And we should ask them to participate, and that may mean them signing up and consenting to go onto the register if they haven't been on the register. I think we need to create online resources. This is to save myself and yourself time. It's best to have some consistent information to give them and to prevent repetition. There's nothing worse than having to tell the same patient everything again and again and again. And by creating an online resource, that could save you the time. And then I think this is now going to be the opportunity where we really do activate our patients to help self-manage and self-monitor. Okay. Another thing, what we are doing is we're delaying or reducing infusions. So we're pushing out adalimumab infusions to 6 weekly on everybody, except if they've just started. Again, if people have just started natalizumab, we're doing monthly for 6 months and then switching them to 6 monthly. And the reason why we're doing monthly is because if you increase the time between infusions or delay infusions in the first 6 months, you may put them at increased risk of getting anti-drug antibodies. What else can I say? I've mentioned to you the unknown knowns. So this is going to be the study that the UK MS Register is going to be running, and hopefully it'll be activated very soon. Richard Nicholas and Nikos Evangelou are the PIs on it, chief investigators, and it's going to require a team effort. And then I'm also hoping that we will create evidence-based science education to try and educate people, kind of what we've done with Listeria, for example, in the COVID-19 space. And then I'm also going to urge you, please, to fight fake news. There is so much fake news going on out there that it's actually causing a lot of anxiety on our patients. And we need to get into the online space. We don't want another CCSVI, and if we don't do this, this will happen. So I'm actually going to ask all of you to volunteer, first of all, to help with the COVID-19 and MS microsite in terms of answering questions. There's only so much I can do. I only have that much bandwidth. And so if there is anybody out there who's keen to help in terms of answering questions and putting them on the website, please do. And also, we also want previous MS Academy graduates to volunteer to do webinars. I think we're going to launch quite a few of these webinars. And just to give you an example, we may want somebody to do managing relapses remotely in the COVID-19 era, how to manage plasticity remotely. Jola Matthews, our MS neuroscience pharmacist, is going to be doing one specifically on prescribing remotely, how to sort out prescriptions rapidly, for example, and how to keep the GPs up to date. I think what we need to use this as an opportunity. Some of us are going to be stuck at home, maybe self-isolating ourselves, having to work remotely. And we must use the time we save from having not to commute to be productive around our jobs and about managing MS. So please, we need volunteers. Any ideas, drop us an email and help. And there are unintended consequences. So I think if there are two things that are going to stick in our mind from 2019, 2020 is the Australia burning and the COVID-19 pandemic. And the unintended consequences that we're saving our planet. This is just showing you NASA's aerial photographs of atmospheric nitrous oxide density. And you can see with the clampdown and the reduction in air travel and travel, we're actually cleaning up our environment. We're cleaning up the atmosphere. So we have to think differently and use this as an opportunity when we come out of this pandemic about saving our planet. So I'll now move to questions. I'll just go up there. Is it reasonable to ask patients on teriflunomide new starters within 6 months to stop and re-challenge at a later stage if they are previously intolerant to injectables? Yes, I think that is reasonable. Actually, to be honest with you, lymphopenia on teriflunomide is quite uncommon. It's usually the total leukopenia that causes the issue. But I agree with you, re-challenge them. Should we defer patients from starting demo for the time being? No, I don't think so. I think what you're probably going to have to do is start them on DNF and maybe be more vigilant about monitoring their lymphocyte counts. And we do it at 3 months and 6 months. And if there's a downward trend below 1, you may want to think about de-risking them earlier than you would normally. But otherwise, I don't think what you've got to realize is only the minority, about 15%, develop a lymphocyte count below 800 and need to be switched. How long, in terms of MS disease control, can we stop cladribine? Well, cladribine is an immune reconstitution therapy, so cladribine is given as short courses. So once you've had your courses and you hopefully responded, you will be in potentially long-term remission, and you'll only need to retreat or offer another treatment if your disease breaks through. With ocrelizumab, it's different. We have data from the phase 2 trial that patients that had 3 or 4, either the 12 or 18 month dose, actually the majority of those patients followed up for further 18 months were neither in terms of no relapses or MRI activity. So I think with ocrelizumab, if you've had 3 or 4, a year or 18 months of treatment, you could probably delay dosing for quite a while, probably months to years with that. So ocrelizumab does give you breathing space after you've had the first, say, 3 courses, okay, or 4 courses. I think alemtuzumab is the same. If you've had your alemtuzumab in the past and you're immune reconstituted and your cell counts are back to in the normal range, you had low risk of infection. Yes, my personal opinion about the natalizumab, if you've got somebody who's on natalizumab and they're JC virus positive with an index greater than 1.5, my personal opinion would be to switch them to extended interval dosing, 6 weekly infusions. That will reduce the risk of PML by about 90% based on the published data from Biogen, from their touch program in the United States. That's now in the European label. And so you may be able to buy yourself some breathing space until the COVID-19 viral epidemic is over. So I think if you just explain to them the rationale behind extended interval dosing, it kills 2 birds with 1 stone. It reduces their risk of PML and it reduces their need to come in every 4 weeks for infusions. For patients who are new relapse after being relapse-free for greater than 2 years on first presentation with disabling with new lesion MRI, we're only able to offer ocrelizumab drugs. Can we offer Tecfidera? I think now, based on the latest changes, actually we're not going to be able to start natalizumab because the European Medicine Agency label, the high activity refers to breakthrough disease on existing DMTs. So the question is from Bindu. For patients who are new relapse after being relapse-free for greater than 2 years on or first presentation with disabling relapses with new lesions on MRI, we were only able to offer ocrelizumab high-activity drug. Can we offer Tecfidera in this situation? I think we can offer Tecfidera. I don't think there's any reason why we shouldn't be able to offer Tecfidera. My personal opinion would be to offer them teriflunomide rather than Tecfidera, simply because teriflunomide has antiviral effects. So if you want to give them some, and the antiviral effects of teriflunomide are pretty broad, covers herpes viruses, JC, BK, Epstein-Barr, CMV, HIV. So it seems to be a mechanism of teriflunomide. After the first completed course of cladribine 1 year ago, how long in terms of disease control can we wait to give the second? I think the current guidelines will be if you had a lymphopenia, you could delay it for up to 6 months. I think in the trial data, we've got data up to 9 months showing that the majority of patients will still be protected. But again, we are not giving the full course. So I think we've got about a 9 month, in other words, up to month 21 with cladribine before we feel comfortable or uncomfortable about not redosing. Now, would you postpone Ocrevus next infusion if CD19 counts are less than 1? No, I wouldn't, because most people who are on 6 months for ocrelizumab have no detectable CD19 cells. So the idea is to keep those CD19 cells suppressed. And I suspect the CD19 population we're targeting is not in the peripheral blood, it's probably in deep tissue or in the central nervous system. So I'm not sure if you're aware, I think there's a ceiling effect in terms of MRI activity and relapses, and anti-CD20 therapies are probably targeting other pathology that's beyond the focal inflammatory lesion. So this is possibly why we need higher doses than even the existing 3 milligram dose in most people to target what I call smoldering MS, or the MS that drives disease progression. Okay, if someone on Tecfidera has the lymphocyte count less than 0.8, our practice is to check and confirm that. If it is less than 0.8, we stop and switch them onto something else. The reason is once you start going down, you tend to go down further, and the lower and the longer your lymphocyte count remains suppressed, the slower the recovery of the lymphocyte count. So if you pick it up very early, stop the Tecfidera, and you see the lymphocyte count return, yes. So we don't know what causes Tecfidera on fumarates, but when it does occur and it's prolonged, it takes many, many months and sometimes. I had one patient that took over 2 years for a lymphocyte count to get back to a level where we could treat her with alemtuzumab. So I think we're going to have to call it. This is obviously a lot of questions people want to ask. So what I'm going to suggest we probably do is reschedule another one, or maybe just have a case study driven one where people can forward case studies. I think that's what we're going to do. We'll have another webinar maybe in a week or 2 weeks' time.
Yeah, I've got
or a series of webinars where we actually discuss case studies.
Yeah.
I think
we'll also be able to, once this video is uploaded onto the website, we'll be able to do a question and answer session on there on the web page as well. So I'll direct everybody to there if there's any more questions that anybody has.
And I'll also put my slides online, and you can distribute the slides to everybody.
Yeah, we'll sort all of that out. Thank you.
Sarah, could you send around a survey just to see what the feedback on the talk is, what if it was too much depth, not enough, too much content, and what they would change?
Yes, of course. And the next webinar is at 14:45 with Sharmali, and there's a link on the right hand side if you want to register to sign up for that one this afternoon. But again, that one will be recorded and it'll be live on the website this afternoon.
I see Rachel Dorsey just put a comment up there saying that the London MS pharmacists are drafting guidance on a change to the blood monitoring, which is going to be very, very useful. Rachel, could you also please try and address whether or not we should be asking the general practitioners to help us out by doing local bloods for us rather than having to travel in and being exposed to crowds on public transport. This is particularly relevant to London, maybe not so much people outside London.
Yeah, I can certainly try.
Yeah, we don't even have a parking lot at our hospital, so patients, really can't come in by car.
Fantastic. Well, we'll upload this, and if there's any further questions, we'll direct you to the website where you'll be able to ask those. And say if you would like to join the afternoon website webinar with Sharmali, please use the link on the right side to join.